Hi everyone, my name is Faisal. I'm a third year medical student, and today I'll be giving you this talk on hematopoiesis and leukocytes. So basically, you took this over like four lectures: hematopoiesis part 1 and 2, and leukocytes 1 and 2. I combined them all into one lecture, and I made sure to include leukocytes through the hematopoiesis part so you can link it better. So just an advice: when you want to study those lectures, try to study them together because they're all interconnected. And of course, if you have any questions throughout this, feel free to text on the chat box. Or later on, of course, this is my number. You can always feel free to text me. So let's get started. First thing, let's break down the word hematopoiesis. What do you guys think hemato means? Yes, it means blood. So hemato itself is blood. Poiesis is basically forming, or basically the process of forming or making. So hematopoiesis is basically the process of forming those blood cells. Those blood cells can be neutrophils, eosinophils, white blood cells, any red blood cells, thrombocytes, or anything. So the process of forming those cells is called hematopoiesis. Now, as we said, it's the main category, or like the main umbrella is forming the blood cells. But there is subdivisions in this hematopoiesis. We have something called erythropoiesis. Again, poiesis is forming. Erythro is from the word erythrocyte, which is another word for red blood cell. So it's basically the process of forming red blood cells. Thrombopoiesis, again, poiesis is forming. Thrombo is thrombocyte, which are basically platelets. So it's basically the process of forming the platelets. Another subdivision is monocytopoiesis. Again, poiesis is forming. Monocyte basically is the white blood cell, which then is when it goes into tissues, it becomes macrophage. So the process of forming this monocyte is called monocytopoiesis. Lastly, you have something called granulopoiesis. Poiesis again is forming, and granulo is basically forming the granulocytes. And I'll be talking more about what are the granulocytes later on, but basically they're the white blood cells that you can see the granules under the microscope, like the neutrophils, basophils, and eosinophils. Now, something that it's really important for you guys to know is where does hematopoiesis take place? And it's just a pure memorization slide. It's get divided into like three stages. So fetus, infants, and adults. For fetus, it also gets divided more. You have from 0 to 2 months, it happens in the yolk sac. 2 to 7 months, it happens in the liver and spleen. 5 to 9 months, it happens in the bone marrow. While for infants, it's going to happen in the bone marrow of all type of bones. So in all of the bones, hematopoiesis is going to happen in the bone marrow for the infants. While adults, it's going to still happen in the bone marrow, but for specific types of bones, which are vertebrae, sternum, skull, sacrum, pelvis, and the proximal ends of the femur. An easy way to memorize them, like try to like go with an order. So basically, you start with the skull, and then you're gonna have your sternum and vertebrae, and then the lower part down, you're gonna have your sacrum, pelvis, and the proximal part of the femur. So a question might come and ask you, for example, uh, where does hematopoiesis take place in infants? And the options might be like liver and spleen, yolk sac, or different things. Your answers should be the bone marrow of all types of foods. No, someone asked if we have to know the specific months. No, you do have to know them because they might ask you from 5 to 9, where does it happen exactly? Because you can see that there is difference. From 0 to 2 is yolk sac, 2 to 7 is liver and spleen, and 5 to 9 is bone marrow. So they might ask you this. Okay. Um, Next, let's talk about another concept, which is basically stem cells. Stem cells are basically undifferentiated cells that can divide and form many different cells. And there's different categories for that. We're going to start with totipotent. It's a stem cell that can give you any type of cell you can think of. So it can form all cells. Another thing is pluripotent. Pluripotent is more limited than totipotent, but it still can form a large range of cells. However, it does not form extra embryonic tissue like the placenta. Another category is multipotent. It's more limited than the pluripotent and the totipotent, and it will only give you rise to a specific type of system. So, for example, you're gonna have a multipotent hematopoietic stem cell, meaning that it can give rise to cells that are only like related to the blood, like red blood cells, white blood cells, and so on. So it's more related or limited to one specific organ system. This is the multipotent. While totipotent is the one that's gonna form everything, all the cells. Okay. Uh, Let's do this. We're gonna start with the multipotent hematopoietic stem cell. Again, we said stem cell is basically an undifferentiated cell that can differentiate and form many different cells. And we said multipotent, meaning that it's limited to only one specific system. So when you have a multipotent stem cell, it can divide into two things. It can either be a common myeloid progenitor or a common lymphoid progenitor. For the common myeloid, it still has divisions under it. You're going to have the megakaryocyte, which is basically the cell that's before the platelets. This megakaryocyte is going to break down into platelets. I'll be talking more about this later on. Another thing that comes from your common myeloid progenitor is your erythrocytes, which are basically the red blood cells. And another thing is myeloblast. Blast is basically a baby. It's like not the developed one, not the final end product. So a myeloblast can give you the basophils, neutrophils, eosinophils, and monocytes. So basically, again, you have the multipotent hematopoietic stem cell. It can give you the common myeloid or common lymphoid. Myeloid is more about the white blood cells and the red blood cells, while lymphoid, from its name, lymphoid is for the lymphocytes. And we know that you have two types of lymphocytes, the B lymphocyte and the T lymphocyte. Okay, again, so we said hematopoietic stem cell, myeloid, and lymphoid. Myeloid is mainly like the red blood cells and the white blood cells that are like the granulocytes one, while the lymphoid is going to give me the T lymphocyte and the B lymphocyte. Okay, now you might be asking, like, what will tell this stem cell to turn into this? Like, how would the stem cell know I want to turn into an erythrocyte, or I want to turn into a lymphocyte, or for example, a basophil? How will it know? There are specific factors that will help it to change from this stem cell to either a lymphocyte or erythrocyte or megakaryocyte. And this is basically the process of regulation. It can happen by two ways. You're gonna have the stroma cells or the humoral, which is basically hormones. Let's start with stromal first. Stroma cells are basically your endothelial cells, your macrophages, and your fibroblasts. Usually, they can secrete like chemicals, for example, interleukins, and those interleukins can act on the stem cell and tell it, for example, to change into a specific thing. And we'll talk more about those specific things in the upcoming slides. For humoral, it's more about the hormones. Sorry. Yeah. So it's more about the hormones. So, for example, the kidney releases a hormone which is called erythropoietin. Erythro is erythrocyte. So from its name, you can know that this erythropoietin will basically help this stem cell to change to an erythrocyte, meaning that it's going to stimulate the erythropoiesis, which is basically the formation of your red blood cell. This is erythropoietin. Now, the liver releases a hormone which is called thrombopoietin. Again, from its name, thrombocytes, which are platelets. So from its name, you can understand that it's the one that's going to stimulate to form more platelets or stimulate the process of megakaryopoiesis or thrombopoiesis. Megakaryopoiesis, as we said, is basically the cell that's before the platelets. Another hormones or like growth factors are the GCSF and GM-CSF. Those are the ones that are going to act on the common myeloid progenitor. Okay. Let me check if there's any questions. Okay. Now, this table, Dr. had put it in his slides, and it's really, really important to memorize it. The questions can come this way. They can tell you, for example, what acts on the committed progenitor cells, or what acts on multipotent stem cells, or what acts on stroma cells. So basically, you want to know what acts at this stage, what acts at this stage, like what are the hormones acting at each stage. So, the ones that you have to memorize, only the thrombopoietin, erythropoietin, GCSF, and interleukin 1. Those are the important ones that you have to know. So, for example, thrombopoietin can act on the common committed progenitor cells and the multipotent stem cell. So it can act on two things. This is really important to know, that it can act on the multipotent stem cell and the committed progenitor cell. For the GCSF, it can also act on both, and erythropoietin will only act on the committed progenitor cells, while interleukin 1 is going to act on the stroma cells. So basically, this is mainly memorization. Try to memorize thrombopoietin, erythropoietin, and GCSF. Well, later on, I think I have a question on it. So focus on this. Okay. Now, let's say you're looking under a microscope and you see different cells. Can you know this cell is a stem cell, like just from looking at it? Exactly. No, you can't know if this is a stem cell or not. You have to do more tests and you have to know specific criteria to tell that this cell is basically a hematopoietic stem cell. Those criteria are that it has to be multipotent. Again, we said multipotent, meaning that it's limited ability to differentiate, but it can differentiate into like one specific system. Second thing, which is really important, that is CD34 positive. Each cell basically has like a marker that marks the cell. For example, you know that the lymphocytes you have CD8 and CD4. Hematopoietic stem cell has CD34. So when you have a cell that has CD34 marker, you know that this is a hematopoietic stem cell. So we said multipotent, CD34 positive, and another thing that it can differentiate and self-renew, which is basically what a stem cell is, that it can differentiate into many things and it can also form itself. So again, so how do you know this is a stem cell? You have three things: multipotent, self-renewal differentiation, and the most important thing that is the CD34 positive. So a question might come in the exam and telling you what are the features of hematopoietic stem cell? And an option can be, for example, totipotent and CD34 positive, multipotent CD34 positive, pluripotent CD34 negative. So it's multipotent and CD34 positive. Okay, now we're going to talk about two processes of how to extract the bone marrow. Uh, how to extract the bone marrow. You have two things. You have bone marrow aspirate, and you're going to have a bone marrow biopsy. The process is like this. You get a needle, and you're going to go to the posterior iliac spine, and you're going to insert this needle into the posterior superior iliac spine, and you're going to collect the fluid. Either you're going to collect the liquid bone marrow or the solid. The liquid is basically the aspirate, while the solid one is the bone marrow biopsy. So basically, when you collect the fluid that's coming out from the needle, you're going to add it to this slide, and then you're going to look under the microscope. This is for aspirate. For biopsy, it collects the solid core of the bone marrow with the same technique. You put the needle in the posterior superior iliac crest, and then you get out, and then you're going to spread it on the microscopic, like the slide. You might be wondering, what is the difference between the aspirate and biopsy? Both of them you use the needle and you extract it out. But there is a big difference. In aspirate, if you look here, this is how an aspirate slide will look like. Bone marrow aspirate. You can see the cells. Like you can see this is, for example, a neutrophil. This is a monocyte. This is a lymphocyte. So you can see the actual cells. Like you can differentiate what cell it is. Basically, so this is seeing the morphology of the cells. While biopsy, it looks like this. You're seeing more of the cellularity, like the difference between the fat and the cells. Here, for example, you see more fat, and all the things here around are basically your hematopoietic stem cell. So for biopsy, you're basically seeing the architecture and cellularity, while for the aspirate, you're seeing the morphology. Okay, someone was asking what is CD34? CD34 is basically a marker of the stem cell. You know how lymphocytes can either have like CD4 or CD8. So basically, it just marks that this cell is a stem cell. Each cell has a marker on it. Is that clear? Okay. So again, let's recap the aspirate and biopsy. Aspirate, you're seeing the morphology of the cells, while biopsy, you're seeing the cellularity or the architecture. For cellularity, where we have an equation, which is basically 100 minus age. So let's say, for example, a patient comes in and he's 20 years old, and you take the bone marrow biopsy, because we said biopsy is the one for cellularity, while aspirate is for the morphology. What do you think the cellularity is? What's 100 minus 20? 80. Okay, yes, as you guys said, it's 80. You take the bone marrow biopsy and you see this. Do you think this is the actual cellularity of the person? Like, is this his normal cellularity? Is this how 80 should look like? Yes, no. Meaning that this patient does he have hypocellularity, hypercellularity, hypocellular, exactly, as you guys said. This is a hypocellular. Because we said 100 and he's 20 years old. So 100 minus 20 is 80. 80, you're supposed to see more stem cells rather than those white spaces, which are basically like the fat cells. So basically, this is a hypocellular. Now let's go for another example. 100 minus another age. Let's say, for example, A patient is 70 years old, and you do 100 minus 70, which is, okay, yes, I get some people are asking the questions like, if is he 100 years old? I remember Dr. Rehan said that you don't have to worry about this, but you just know that he's gonna have really low cellularity. 100 minus 70 is 30, yes, as you guys said. And does this does this look like 30 for you? Well, is it hypo or hyper? It's hypercellular, exactly. So, as you increase in the age or as the person gets older, the cellularity decreases. Because again, for example, 100 minus 50 is 50. This is what a 50-year-old patient is. 100 minus, as مثلا 100 minus, if you're, okay, you can't be like 100 years old, but like, I mean, for example, another thing, let's say a newborn, he has like 100% cellularity. So as you age, the cellularity decreases. Okay, is everything clear so far? Is there anything you guys want me to recap on? Okay, if everything is clear, I have a question for you guys. Okay, wait, you want me to recap the table? 1 minute. Let's go back to the table. Okay, for the table, it's pure memorization. You just have to know that thrombopoietin, erythropoietin, and GCSF are gonna act on your committed progenitor cells. Thrombopoietin and GCSF. Just know thrombopoietin, erythropoietin, GCSF. Those are the main three ones. Thrombopoietin GCSF is gonna act on multiple potential stem cells, and interleukin-1 is gonna act on the stroma cells. I put interleukin-1 because I remember in our exam on batch 16, we got a question on interleukin-1. They were like, which factor acts on the stroma cell? And we got interleukin 1 and thrombopoietin, erythropoietin, and so on. So the only one that acts on stroma cell that you have to know is interleukin 1. I went over your transcriptions. Dr. Rehan said just know thrombopoietin and erythropoietin, but just in case, just know that interleukin 1 is acts on stroma cells. Is that clear? Okay. Yes. So no thrombo, erythro, and GCSF as well, and maybe interleukin 1. Exactly. So now I have a question for you guys. Which is related to the table. Because you got a lot of questions on this table, so please make sure to memorize it. Okay, okay. Yes, yes. Okay. Y'all got it right. It's thrombopoietin. So again, if you look back to the table, thrombopoietin is the one that's gonna act on both of them. Interleukin 1 is the one that's mainly gonna act on your stroma cells. Erythropoietin is the one that's gonna act on your progenitor. So the question is asking you which one acts on both. So that's why the answer is thrombopoietin. Okay, now let's go into hematopoiesis in more depth. Again, we said it's the process of forming the blood cells, and you have many different processes under it, like subdivisions, which are basically lymphopoiesis from its name lympho, you're forming the lymphocytes. Granulopoiesis, granulo, you're forming the granulocytes, which are basically eosinophils, basophils, and neutrophils. Monocytopoiesis, basically you're forming your monocytes. Erythropoiesis, erythro, you're forming your red blood cells. And thrombopoiesis, megakaryopoiesis, you're forming your platelets. Let's start with erythropoiesis. Again, poiesis formation, erythro forming your red blood cell. Okay. So you start with something which is called the proerythroblast. Again, blast, remember it as like something that's immature, not yet. It's a baby. It's not the final product. You start with the proerythroblast, and then you go with early, intermediate, late, normal blast. Dr. Rehan said that you don't have to memorize those names. Just know early, intermediate, late, normal blast. And then you end up with the reticulocyte, which is basically the immediate precursor of red blood cell. So after this, exactly is going to be the red blood cell. So just looking at this diagram, what do you guys think changed? Like from this going to this, what are the things that you can see like visually? Exactly, the nucleus is getting removed. And what's another thing? Color, exactly, as you guys said. So You can see that the nucleus, which is this one, is getting removed, getting removed, getting removed. So that's one thing, the nucleus is gone. And another thing, it's becoming more red, meaning that you're gonna have forming more hemoglobin, and formation of hemoglobin is basically the red, which gives the red blood cell its color. So from the pro-erythroblast to reticulocyte, the nucleus is getting removed, and another thing is becoming more red. Now let's talk about reticulocyte more. So we said reticulocyte is basically the immediate precursor uh, before the red blood cell. So reticulocyte, then directly after it, the red blood cell is gonna if you look at this, basically they stained this by something called supervised stain. I don't think you have to know the name of the stain. However, just know it's by staining technique. So they stained it, and you can see those blue things. Do you guys know what those blue things are? Yes, reticulocyte is an immature red blood cell. It's basically just the immediate precursor before it directly. Okay, yes, as you guys said, this is the RNA remnants. So in reticulocytes, it's as we said, it's the immediate precursor. It does not have a DNA, however, it has remnants of RNA. So it does not have a DNA, but it has remnants of RNA. Now, the reticulocytes, after directly, it's going to happen, they're red blood cells. The red blood cell does not have DNA and no RNA. So now, if you want to compare the differences between the reticulocyte and the red blood cell, both of them do not have a DNA. Reticulocytes has those fragmentation of this RNA, red blood cell don't. And you can find both the reticulocyte and the red blood cell in the marrow and the blood. You have to know this. That's where each cell is going to be found, like, in those two. Both of them can be found in your bone marrow and the blood. Okay, I added this slide just for completion's sake. I don't know how important it is, but I thought maybe a question can come. The main thing Dr. has stressed on for this slide that he said that division, you have here the pro normoblast, and then you get your early, intermediate, and late. It keeps on dividing, dividing, dividing. At the stage where this division ends is the late. I don't know. I felt it can be an exam question, even if it's low yields, it might come. So just know that division ends in the late normoblast. Okay. Now, again, we said, how will the stem cell know that I want to change into a red blood cell or I want to change into a white blood cell? It's all about hormones. So, erythropoietin is the one that's going to tell the stem cell to change into erythrocyte, which is the red blood cell. And it's going to get released from kidney. This is really important to know that erythropoietin is getting released from your kidneys. And the main trigger for it is hypoxia, low oxygen. So when the body sees that there's low oxygen, this triggers the kidney to produce more erythropoietin. Why? Because it wants to form more red blood cells. And what's the function of red blood cells? They carry the oxygen. So it all like makes sense. And what does it do again? As we said, it increases the number of red blood cells by increasing the process of erythropoiesis. But it's going to increase the number of the progenitor cells. Now, why do you think this is clinically important? Let's say, for example, a patient comes in and this patient has anemia, and the cause of this anemia is renal failure. Like his kidneys are no longer producing erythropoietin, which is basically the hormone that's necessary to do the process of erythropoiesis and make the red blood cells. So, if your kidney is not producing erythropoietin, the doctor has to do something. So they give you injections of erythropoietin. You have like those medications, erythropoietin, which will help the erythropoiesis process to happen because the kidney cannot release it. So you have to give it from outside. So this is really important to know that erythropoietin is given in people that have chronic renal failure because again, kidney is the one that's responsible for releasing the erythropoietin. Okay, another pop quiz. Which of the following best describes reticulocytes? Okay, yes, perfect, perfect. Yes, as you all said, it's D. So there is RNA, there's no DNA, and it's found in the blood and bone marrow. By the way, guys, all the pop quizzes I put are from previous batches, like from our actual exams. So even if you think the information is low yield, but it still comes. Like I didn't know that this information is important. So yeah, so it's important to solve past questions and keep it a secret. Okay, now we're done with the process of erythropoiesis. Now let's talk about granulopoiesis. Granulopoiesis is basically forming the granulocytes. Okay, before that, leukocytes are basically white blood cells, and leukocytes are divided into two things. Granulocytes, which are basically neutrophils, eosinophils, and basophils. Granulocytes meaning that under the microscope you can see granules, which are those things. Those are the granules. And you have A granulocytes, meaning that under the microscope, A is like without. They do not have granules, which are basically like monocytes and lymphocytes. Another way of classifying them or naming them is polymorphonuclear cells. Poly meaning like multiple, nuclear. Why did they name it this way? Because you can see that the nucleus looks like it's segmented, or it can look like more than one. Like you can see like one, two, three, one, two, and so on. So that's why they called it polymorphonuclear. While for the A granulocyte, it's just like one fat nucleus. This one is indented, but it's still like one. It's just like the monocyte, the nucleus looks like a kidney shape or like a C shape. So they call it as mononuclear cells. Okay, now let's go into the process of forming those granulocytes. So we said granulocytes are the neutrophils, eosinophils, and basophils. Okay. Again, we're gonna start with myeloblast. Again, we said blast is basically the baby cell, which is basically the one that's still the precursor of the final part. This myeloblast can then go change into promyelocyte, and then myelocyte, and then metamyelocyte, and then a band cell, or another name for it is a stab cell, because it looks like someone stabbed it, like with a knife. That's called a stab cell. So in an exam question, they can tell you in the question itself, they can refer to it as a stab cell, or a band cell, or a left shift neutrophil. So all of those are just the same thing. This is a segmented, which is basically the end product, which is urine neutrophil. So, what same question I asked for the erythrocytes? What changes do you guys see here? Starting from this myeloblast to the segmented one. What are the things that you can see like visually? Okay. Okay, someone said appearance of granules, which is correct. Something else, exactly. Nucleus becomes more segmented. So as you guys said, first thing, the nucleus becomes more segmented. You can see here it looks like one fat nucleus, one fat, and then it starts uh, being more like dented or like segmented. And at the end, you can see it's getting more segmented. And another thing is the appearance of the granules. You can see here that the granules are basically like those are the pink granules. And then مثلا in myelocyte, you can see pink and new granules come with it, which are those like greenish ones. And then in the band cell, you can see a third type of granules coming, which is basically the, yeah, here, which are the purple ones. So again, what happens is the nucleus gets segmented and you're going to find the presence of the granules. Okay. So you have to know this, that we have three types of granules. You have the primary, secondary, and tertiary. You have to know where does each granule appear. So promyelocytes, you're gonna have in it the primary, and an easy mnemonic way. Pro starts with a P, and primary P. So promyelocyte is gonna have the primary granules, and those primary granules they have something called myeloperoxidase, which is basically an enzyme that will help the neutrophil kill the bacteria. So again, promyelocyte is the stage where the primary P myeloperoxidase. The segmented one at the end is the neutrophil. Lymphocytes, they have one big nucleus. It's segmented and it has granules. This is a neutrophil. Lymphocytes, they have a one big and they're agranulocytes. They don't have granules. Okay. For myelocytes, you can see the secondary granules are appearing, and they have something which is something called NADPH oxidase. So basically, they regenerate reactive oxygen species that will help also killing the bacteria. So it's very important to know that in pro is going to be the primary, and it's going to have myeloperoxidase. Myelocytes is going to have the secondary, and it's going to have the NADPH oxidase. The tertiary is going to come here at the band cell or the staph cell. So again, primary is in the pro, secondary in the myelocyte, and tertiary is the band cell. Okay. Now, what do you guys think this cell looks like? Exactly, staph cell, or another name, band, exactly. So either a band, stab, or left-shifted neutrophil. So for each cell, I want you guys to know two things: the number of nucleuses and the amount of granules, or like what granules is present here. So what do you think for the granules? What granules are seen here? What granules are going to be seen at the band cell? Yes, all three granules. Exactly. All three granules, and you can see that it has two lobes. This is like one, and this is another one. So again, I want you guys to know the granules and the number of lobes of the nucleus. So you're gonna have two, and you're gonna have the three granules. And in the band cell is the part where the tertiary granules are gonna appear. But again, you're gonna have the accumulation from the beginning. You're gonna have the primary and the secondary and the tertiary granules as well. Okay, now, what do you think this cell is? Exactly, as you guys said, neutrophil. And again, the same thing. I want you to comment on the number of lobes for the nucleus. How many lobes can you guys see? Three, perfect. Neutrophil is anything from between three to five lobes, but in this picture exactly it's three lobes, as you guys said, and it's gonna have all the three types of granules, and it's basically the most abundant white blood cell. So, we said again we have many different white blood cells, but the one that's gonna be in the most number is basically neutrophils. So, I want you to know the number of lobes, the granules, and I also want you to know the function of the neutrophils. The function of the neutrophils are phagocytosis, and it's basically the first line of defense. Is that clear? So again, as we said, it can have all three granules, it's three to five lobes, and the function of it is phagocytosis. Now, we have to know, again, as we said for the erythrocyte part, that erythropoietin is the one that's going to act. Now, what hormone or what growth factor is going to act on the myeloblast to give me the neutrophil? This is the GCSF. This GCSF is basically going to be released from the stroma cells. And what does it do? It will stimulate the bone marrow to make more neutrophils. Again, why is this clinically important? Let's say a patient comes in and he has really low neutrophils, maybe because he's post chemo or like there's a severe infection or post radiotherapy. All of those things, the neutrophils in the patients are very low. So I have to give something to increase the number of neutrophils and to increase the process of this forming the neutrophils. That's why you can give GCSF injections as well. Okay. Now, what do you think this cell is? Eosinophil, exactly. And eosinophil, why do you guys think that? How many lobes can you guys see? Red granules, exactly, red granules. The most important thing is the red granules, and it's the bilobe. Here you can see this is like one, and this is another one. If you can't really see it, no problem. Just know that eosinophils are bilobe, and you can see the amount of red granules. Okay, and you have to know what the granules have. The granules basically have nitric oxide and major basic protein. Those are the two things that are going to be found in the granules of the eosinophils. And its function, it's mainly against parasitic infections. It's also, you can also find it involved in the allergic reactions, but mainly it's the parasitic infections. Because the allergic reactions has another type of white blood cell. So again, eosinophils, besides its bilobes, its function mainly in the parasitic infections, and you're gonna have those granules, which are gonna have the nitric oxide and major basic protein. Those nitric oxide and major basic protein basically will help in the defense system against the parasitic infection. So they will help to kill the parasite, and it can also help in wound healing. Now, what do you think this cell is? Yes, exactly. As you guys said, it's a basophil. Again, we're gonna comment on the granules. What color granules do you guys see? Purple, yes, darkish bluish purple. And it's bilobe. Yes, you can see it because of the amount of the granules on top of it. That's why you can't see the lobes. But just remember basophils be bilobe. So basophils are bilobes, and you can see those dark green purple granules. And what's the function of basophils? What does it fight against? Or like when is it elevated? Exactly. As someone said, the granules have histamine and heparin. Again, histamine and heparin, histamine is basically a vasodilator, and heparin is an anticoagulant. And those granules, those contents of those granules help to mediate the allergic response. So the granules here have heparin and histamine, which will help in the allergic response and in the inflammation. Now we finished the granulopoiesis, which are basically the eosinophils. We talked about the basophils, and we talked about the neutrophils. Now we're going to talk about the monocytopoiesis. Again, poiesis forming. Monocyte, meaning that I'm forming the monocytes. So monocyte, is it an agranulocyte or a granulocyte? Agranulocyte, yes. You can't see the granules, but you can't see dots here. What I'm meaning by granules are like basically you can see the dots here. Those are the granules under the microscope. So it's agranulocyte and it looks like a kidney-shaped nucleus. This is really important because in OSPI, for example, they can give you the slide and they tell you what is this cell and give me two identification points. Like, why did you say this is this cell? So you say this is a monocyte, and the two identification points are that it's a kidney-shaped nucleus and something else that does not have granules. And the function of those monocytes, it will also help in phagocytosis. Monocytes, when they go into a tissue, they change the names, and the name is now called a macrophage. So it basically it will capture, for example, like it will engulf the bacteria and then present it by the antigen-presenting cell, the whole immune system process that you guys most probably took in your immunity lecture, most probably. So just know that monocyte is a kidney shape, so it's a granulocyte, and it helps for phagocytosis. Okay, so we finished erythropoiesis, monocytopoiesis, and granulopoiesis. Now we're going to talk about lymphopoiesis, which is lymphocytes, forming the lymphocytes. Again, we said each cell before that has a precursor, and the precursor usually ends with the blast. Oops. Usually ends with blast because, again, it's the baby immature one. And as you can see, the shape of this lymphocyte, first thing, how many nucleus can you see? Like, how many lobes of nucleus? One, exactly. So this is one identification point that it has one lobe of nucleus, it's just one huge central nucleus. And does it have granules or is it agranulocyte? No granules. Okay, exactly, as you guys said. And you can see that it's a bit bigger than the red blood cells. So if you compare it, you can see that it's a bit bigger. And the ratio of the nucleus to cytoplasm, like is the nucleus taking most of the space? Or is it not? Like, is there a little cytoplasm? Or yes, exactly. As you guys said, you can see that there's literally like a little rim, a thin rim of cytoplasm here. And the function of it, first thing, lymphocytes, we have two things, B lymphocytes and T lymphocytes. Again, you're gonna know this more in your immunity lectures. B lymphocytes are the ones that are going to produce antibodies, while T lymphocytes, you're gonna have like the T killer cells and so on, which are basically the ones that's gonna destroy those infected cells. Do you guys think if I give you the cell, can you tell me this is a B or a T lymphocyte? Is that possible? Exactly, no, it's not possible. So just by looking at the cell, you can't say it's a B or a T lymphocyte. You have to see like the markers. Does it have CD4? Does it have CD8? And so on. Okay. In the leukocyte lecture, the doctor kept has like percentages for each neutrophils, eosinophils, basophils, monocytes, and lymphocytes. You guys don't have to know that. All I want you to know is neutrophils is the most abundant one. After it comes lymphocytes. The least one is basophils. So you don't have to know the numbers, just know like the concept that neutrophils are the most and basophils are the least. So now we're done with lymphopoiesis, granulopoiesis, monocytopoiesis, and erythropoiesis. Lastly, the thrombopoiesis and the megakaryopoiesis. Monocytes are the kidney shaped ones, yes. The difference between lymphocytes and basophils is the granules, as we said. The plus basophils is bilobed. A lymphocyte is just only one central lobe. And the function of monocytes is basically phagocytosis, engulfing the pathogen or bacteria and breaking it down. Is that clear? Perfect. Okay, now let's talk about thrombopoiesis. Poiesis again is basically formation. Thrombo is from the thrombocyte, which is basically platelets. Again, we start with a megakaryoblast. Again, blast meaning a baby, an immature one. This, oops, okay, sorry. This megakaryoblast is going to change into a megakaryocyte. This cell is really important to know. The morphology of this is really important. Like you can see it, I can see it right now in your OSPE exam, the first question, and they're telling you what cell is this, and for example, what hormone can act on this cell to give you platelets. So this cell is really important. If you see something huge, this is the mega. From its name, mega, it's a huge cell. Okay. The liver releases a hormone which is thrombopoietin. Again, thrombopoietin is the one from its name thrombo is going to stimulate the formation of those thrombocytes. So this thrombopoietin is going to act on this megakaryocyte, and let's say this megakaryocyte explodes and gives me those small fragments of cells, which are basically platelets. So what is the hormone that's going to act to give me the platelets? Thrombopoietin. And the one that's going to act to give me the erythrocyte, erythropoietin, and the one that's going to give me the lymphocyte, the neutrophils and so on is GCSF. Yeah, so mega cells use the thrombopoietin. Yes, exactly. Yes, exactly, as you said. Okay, checkpoint. Is everything clear so far? We're almost done. It's such a short and simple lecture. Someone asked when they ask these questions in the OSCE, will it be MCQ or we have to type the answer? You most probably type the answer, like they're gonna give you this picture, and then let's say part A is like, what is this cell? Part B is give me two identification points. So you'll have to type the answer. It's just like one short word. Like you don't have to write paragraphs or anything. For like this lecture especially. It's okay. Someone said if I misspell words, it's no, you don't lose points. Okay. Now, another concept that I guys want you to know is the differential count versus absolute count. Differential is basically just the percentage. So it just shows you how much of this type of white blood cell is present, which, for example, that neutrophils we know is the most abundant one, but percentage-wise is 70%. But if I actually want to know the actual amount of each white blood cell, you have a formula, which is basically you get the percentage of the cell type. Let's say the neutrophils you have 70%. 70% multiplied by the total white blood cell count. So for example, in the exam, they might tell you, for example, give me the absolute count, because they'll give you everything. They'll give you the total white blood cell count, and they'll give you the percentage of the cell. So the only thing you have to know to do is multiply them. When you multiply them together, you get the absolute count. I don't think it's a high concept, but just know it, uh, yeah, to be safe. Okay. Now, I want to talk about three terms that are really important: penia, philia, and cytosis. Do you guys know what penia is? Like, let's say, for example, neutropenia. Low amount, exactly. No, penia is no, is low. And it applies for granulocytes and agranulocytes. So, for example, you can say neutropenia, lymphopenia, all of those, meaning that there's less from this specific cell type. Philia is the opposite, is high count. This is high count for granulocytes. So basically, you say neutrophilia, basophilia, eosinophilia, meaning that you're gonna have a lot from this specific type of cell. Cytosis is also a lot, but for the agranulocyte. So you're going to say lymphocytosis, monocytosis. Like you're going to have a lot from the lymphocyte or the monocyte. You can't say lymphophilia. Philia, the term philia is only used for the granulocytes, which are basically the neutrophils, basophils, and eosinophils. Now let's talk about neutrophilia. Again, philia, which is a lot, and which is basically the neutrophils. So when you're gonna have a lot of neutrophils, there's two types of that. You're gonna have the mature and the immature. The mature meaning that you're gonna have a lot of neutrophils. You can see that you have a lot of neutrophils here. Uh, Dr. Rehan most probably will get you the same exact photos, so just memorize them. And this is, oh, you can see it. I mean, there's a lot of neutrophils here, but this is called neutrophilia. This is the mature type. The immature type is you can see a lot of those cells. What do you guys think this cell is? What does it look like? Stab cell, exactly, stab or band cell. So immature from the name meaning that I'm having more from the immature cell, not the final neutrophil. So you're having more of the stab cell or the band cell. Okay, something you have to know is what causes this neutropenia. So for example, let's say a patient comes in with a bacterial infection, he'll most probably have high neutrophil counts. So that's why neutropenia. So the most common cause for both of them, the mature and the immature, is the bacterial infection. So a patient comes in with a bacterial infection. What can you see? Neutropenia, increase in number of neutrophils. Another cause can be steroids and stress and hormones. I just added them for the sake of completion, but the most important thing is bacterial infection. For the immature, again, a bacterial infection is the most common, and you have something called the chronic myeloid leukemia. This again, the most important thing is the bacterial infection in both cases. So in the mature and the immature, the most common cause is bacterial infection. Yeah, you have to say bacterial infection because viral infection is, for example, for lymphocytosis. You have to say bacterial infection. You can't just write infection in the exam. Now let's say, okay, there's some toxic changes. Let's say the bacteria now is fighting this pathogen, is engulfing the pathogen. Let's say the bacteria is the one is the bacteria is basically the one winning, not the phagocyte, not any the lymphocytes, sorry, for example, not the neutrophils, sorry, not the neutrophils. So صح, the neutrophils do phagocytosis for the bacteria. Let's say the bacteria is the one winning this fight. You can see something called cytoplasmic vacuolization, which is basically the bacteria poking holes in the cell. So they might get you this picture and they tell you what is this. You have to know in the cytoplasmic vacuolization. And when does it happen? It happens when the bacteria is winning. So the neutrophils are not killing the bacteria. The bacteria is the one that's winning this fight. And another thing that you can also see in toxic changes is toxic granulations in the left shift neutrophil. Again, left shift neutrophil is the same as the band and the tap cell. So this is the most important one. For cytoplasmic vacuolization, you can see that the bacteria is basically poking holes in this neutrophil, meaning that the bacteria is winning the fight. Okay. Here, you can see that those are eosinophils. Why is it eosinophils? Because you can see they're like bilobed and you can see the red granules. Let's say a patient comes in and he has a parasitic infection. So what's the main cause of eosinophilia? Parasitic infection. And another thing also allergic reactions, but mainly parasitic infection. So if a patient comes in with a parasitic infection, most probably when you do the labs, you're going to see that they have a high amount of eosinophils. So eosinophilia. Philia is more, a lot. Now, those are basophils again, because you can see the dark blue purple granules. So when there's a lot of basophils, the most common cause of basophilia is chronic myeloid leukemia. The doctor had this written 3 times from how important it is. But remember, it came in every single exam, like 16, 17, 15 batch. So this is really important to know. You know, they might ask you what's the cause of basophilia. The only thing the doctor wants you to know is chronic myeloid leukemia. Okay. Cytosis, as we said, is basically the increase in the amount, but mainly for the lymphocytes, for the agranulocytes. For the granulocytes, we use philia. So for lymphocytosis, two things. You can see mature ones, meaning that you can see an increase in the mature lymphocyte, which is basically the one that has one lobe and so on. Another thing, you have this reactive lymphocytosis, which you can see those cells, which they call it like funny cells, those funny cells. And the most common cause for lymphocytosis for both of them is the viral infection. So we said for the neutrophils, which is neutrophilia, mainly bacterial infection. For lymphocytes, the most common thing is the viral infection for both of them. Sorry. Yeah. So for both of them, the most common cause is the viral infection. Another cause for lymphocytosis is the chronic lymphocytic leukemia. For this one reactive, which looks like those funny lymphocytes, it happens in a viral infection. There's a virus which is called ABV, which is Epstein-Barr virus, in a disease which is called infectious mononucleosis. It's also called the kissing disease because it's transmitted by like kissing. That's why it's called the kissing disease. And yeah, just important to know that infectious mononucleosis, you're gonna see lymphocytosis, but the reactive part, which is you can see those funny cells. Wait, can we get back to this one? Okay, 1 second. Okay. I just want you to know here that basophilia, the most common cause of basophilia is chronic myeloid leukemia. I'll be explaining leukemia in the next slide, but for now, I just want you to know that basophilia, which is increased in the number of basophils, is high in the cause of chronic myeloid leukemia. So this is the most common cause of basophilia. Again, lymphocytosis is that you have the mature and reactive. Reactive is the infectious mononucleosis. Okay. Now you can see those are the monocytes. Monocytes because you can see those kidney shaped or like dentation or like C shape. And monocytosis is going to be increased in two cases, tuberculosis or if there's a chronic infection. Chronic infection meaning that this infection lasted more than 10 days. So if a patient comes in with a chronic infection that lasted more than 10 days, you'll expect monocytosis, which is basically increase in the monocytes. And another cause of monocytosis is tuberculosis. Is everything clear so far? Exactly. If you ask about basophilia, you say the most common cause is chronic myeloid leukemia, as we said. Now I have a pop quiz for you guys. Parents bring their 11-year-old son to the clinic who has been complaining about sore throat and coughing for a week. CBC shows neutropenia. Okay. And what is the cause of those of the boy symptom? Exactly, as you guys said, bacteria infection. So, in parasitic infection, what will you see? Eosinophilia. Exactly, a lot of eosinophils, eosinophilia. In CML, what will you see in chronic myeloid leukemia? Eosinophilia, exactly. Okay, another thing. Which of the following presents during infectious mononucleosis? Okay, yes, yes. Someone said lymphocytosis, which is correct. Now, which type is it? Is it the mature one or the reactive with the funny-looking lymphocytes? Immature. Yes, which is the immature one. Which is another name is the react. It's called reactive. The funny-looking, exactly. And do you remember what was the the virus that caused it? What virus exactly? Let me go back to the slide and explain it again. Cytosis basically increase in number. Monocyte meaning that you're increasing the number of the monocytes. And it can be caused by tuberculosis and the chronic bacteria. This is for monocytosis. For lymphocytosis, the reactive one, which was just the question about, it's going to be increased in infectious mononucleosis, which is by EBV, which is the Epstein-Barr virus. Is that clear? So the question the pop quiz was asking that infectious mononucleosis, what can you see? Or where can you see infectious mononucleosis? It's going to be in the lymphocytosis, which is the reactive one. Okay, so okay. Now we're going to talk about the malignancies. So basically, hematologic malignancies are basically cancers that are arising from the hematopoietic stem cell. You're going to have two types, leukemia and lymphoma. And the differences between them is where is this cancer cell? Leukemia is basically a cancer cell in the bone marrow. Yeah, it starts in the bone marrow and then it spreads around. And there's different types. You're gonna have acute myeloid leukemia. Myeloid, because it's from the myeloid progenitor cell. Remember in the first slide when we talked about stem cells and we differentiated them into myeloid and lymphoid? That's where this is coming from. So you have acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia, which is basically from the lymphoid progenitors, acute myeloid leukemia. A is for acute, C is for chronic. Lymphoma is starting from the lymph nodes. So just the difference between leukemia and lymphoma. Leukemia is starting from the bone marrow, lymphoma is from the lymph nodes. And examples they have to know something called Hodgkin lymphoma and non-Hodgkin lymphoma. You don't have to know those examples for now. You take them more in second year. Sure. Okay. Now leukemia. Again, we said you can have the acute type and the chronic type. The difference between the acute and the chronic is the number of blast cells, which are basically the immature white blood cells. If they're more than 20%, this is an acute leukemia. You're going to have the acute myeloid, meaning that it's from the myeloid progenitor part. Acute lymphoid, meaning it's from the lymphoid part. The chronic, if the blast cells are less than 20%. So in the question itself, if they said that the blast cells are less than 20%, this is chronic leukemia. If the blast cells are more than 20%, that's acute leukemia. Okay. Now for the last thing I'm going to be talking about today is acute myeloid leukemia. Okay, two things I really want you to know about this. We said it's acute. So is the blast cells more than 20 or less than 20? If it's acute, more than 20. Exactly. And by any chance, do you guys know what this is? Those lines, what do we call them? Exactly, our rods. So two characteristic things of acute myeloid leukemia. We said leukemia is basically the cancer that arises from the bone marrow. Acute, meaning that the blast cells are more than 20%. And in acute myeloid leukemia, you can see those hour rods. This question is most likely coming in OSPE or even in like MCQ. They might give you this picture and they tell you what is the characteristic of this. And you say hour rods. This is really important to know. Hour rods. Lastly, for the last pop quiz, uh, what is the cell? Can you identify what the cell is and give me one reason for its increase? Okay, so this cell is basophil, as you guys said, and one reason for its increase? Exactly. Chronic myeloid leukemia. All of those pop quizzes I got are from past questions, either our batch or 17th batch. And with that, I'm done. It's a really simple lecture. Just know for each cell, just know three things: the number of lobes, if they have granules or not, and know the function of it. Also, know also what else can you know about this? Yeah, those things, and also know the hormones that act on them. Like for example, erythropoiesis and those. Other than that, it's just a really simple lecture. Oh, good luck, guys, in FND. I know this is your first block. I know this is the first block of like first year, if it might be difficult, but inshallah, you guys are gonna have an easy final. And yeah, if you can please scan this QR code for feedback, and I added more questions here if you want to solve them as well. And my number is in the first slide. If you have any questions, does not have to be about this, anything like studies, anything, inshallah, more, anything, feel free to text me. And for the PowerPoint, we'll upload it right now on the Drive It channel.